Next, we have Dr. Mark Coyne, consultant haematologist. He's also chair of the Health Service Executive Working Group on Amyloidosis, based at St Vincent's Hospital and University College Dublin, and the talk is on pathways to genetic testing. Dr. Mark Coyne.
Go raibh go tá chuile in a bheith an seo, tá sé fear táachta chun an cruinne seo a bhealgan I lár Gweedore. Sorry, I should take off my mask now. I'm really, really happy to be here, and I really must thank the work of Roisin, Anne, Pat, and the rest of the members of the support group. Today I've been asked to talk about the pathways of genetic testing, but following on from Sinead and from the other speakers, I'd like to also share what's happening in the HSE. There we go. So I'll talk briefly about some of the variants. A lot of us have already alluded to the more common variants in Ireland, but it is very important to remember that Ireland is now a multicultural country, and some of the variants we're seeing are not just the Irish variants. And what we have actually seen more often in the Dublin situation is we've picked up sporadic cases, really not cases where there's a clear family history. That's very different to the Derry experience or indeed the Donegal experience. I'd like to touch on the consensus recommendations because around when a person should be genetically tested, who should be tested, and I'm pleased to say that two of the co-writers are on the panel today, Julian and Mary. But in addition to reflect on the other recommendations at an international level, I'll finally kind of work on how that fits within the Irish context and how we move on from that. So as you've already heard, hereditary or variant ATTR amyloidosis is where there's an issue with producing this protein that carries free thyroid hormone and vitamin A. It's present in most populations around the world. You can see that there is some dots in some parts of the world, but that's probably down to not being able to properly evaluate the disease in those regions of the world. The more common types are the V30M, and in this context of Ireland and the UK, the T60A clearly is the most dominant population. However, speaking to Emer even before this meeting, we have identified a V122I mutation within the Irish population also. So although 3.9% of the African American population carries the V122I gene, we see it in the Irish population also. So again, our role as clinicians working in the amyloidosis is trying to broaden out awareness and to think as we've touched upon there, the Amyloid Light book, I'd like that to switch on with our colleagues. If we look at the gene, so spanning the gene that creates the protein, transthyretin, you can see here these are some of the mutations. And as Roisin alluded to, there's over 100 different types. And right in the middle, we can see is T60A. Right to the right-hand side, or to the 3' region, we can see you have a mutation in the V122I, and to the 5' side, the V30M. So again, when a person does genetic testing, it's really important that the full gene is sequenced, all exons, because if you just focus on one part of one exon, you may miss kind of a pathogenic mutation. However, if the family has a mutation already established, then it is very much reasonable to look at that single gene by itself. These are the three main papers that are emerging, and they're emerging really on the, I suppose, appreciation that there is now treatments that begin started early in these patients that then can hopefully change the evolution of their disease state. On the left, we've got the most recent publication, which was largely geared to see could we get a consensus with clinicians in the UK and Ireland on when genetic testing should be done and who should it be done on. So there's three main areas that we covered, and one with people, the first one were people with symptoms raising a possibility of hereditary ATTR amyloidosis. The second, people with biopsy confirmed ATTR amyloidosis. And then the somewhat controversial one of people that don't have symptoms but may have a ATTR amyloidosis variant. And that's the hardest one. And when should we do the testing? There's many people in this audience that have family members, brothers and sisters, who have had ATTR amyloidosis and would like to have the gene tested. But we can see from even the data emerging from the H90D variant and the data that Mary collected many, many years ago on the T60A that there is incomplete penetrance. So you may have the gene, but it doesn't mean that you'll develop the condition. It's very easy to do the gene test. What isn't easy is how do you follow that person? What scan should you do? When should you institute treatment? There's variation of consensus around that. So towards the end of my talk, I'll focus a little bit about trying not just to focus on a drug or a gene test, but try that we should create a service that provides all the needs of the patients with amyloidosis. So firstly, I'll talk with people with symptoms. This is a complicated diagram and it's a little bit largely directed for physicians that may want to diagnose amyloidosis. But you can see if you present with cardiac symptoms, so if you go to see a cardiologist, if you go into the emergency department with cardiac symptoms and then someone's light bulb switches, you can see that down towards the end, that TTR genetic testing then is completed. This is very different to the neurological pathway. And I know Mary and Philip had a lot of discussion about this. I know myself and Sinead had a lot of discussion in our own working group. But when you have a neurologic presentation, there is a feeling because, as we saw in the H90D, that you take a nerve biopsy. It's a very small piece of tissue that even if there is amyloid in it, it's very difficult to type that amyloid in nerve biopsies. We now routinely do nerve and muscle biopsies to try and increase the positive predictive rate. But you can see front and central of this recommendation is that if the neurologist or the physician is reviewing a person that has nerve-like symptoms, so both low blood pressure, problems in the bowel, or pins and needles in the hands or feet, then TTR gene testing is considered much higher up in the pathway. For those that have biopsy-confirmed ATTR amyloidosis, and although working in the area in the specialism of amyloidosis, I do have ongoing, even in 2022, issues where a person is diagnosed with ATTR amyloidosis and the feeling is the job is done, that's okay, that's the diagnosis. But you know in the audience, there's many different types of ATTR amyloidosis, and the most common one that I will see in my clinic where we're trying to distinguish them from AL amyloidosis is the wild type, the unmutated form. That is most certainly the most common form, and it's associated with a very healthy person who, may be jogging, swimming every day, has no other medical diagnosis, and then suddenly they notice a change in their breath. I remember actually when I worked in the NAC with Julian, the first patient that I met over there, he used to cycle the Alps 3 times a year, and the first symptom he had was that he was moving the gears a little bit more rapidly as he ascended. He had a cardiac MRI done, and he was, lo and behold, diagnosed with wild type. So the one we see more commonly is wild type ATTR amyloidosis. It's very much invariably associated with their centurion. So most people, when they hit 100, will have a little bit of amyloid in their heart as well. So something to look forward to for those lucky people in the audience. With biopsy confirmed, we absolutely recommend that all cases have a genetic test completed. And that allows us to tell us, do you have the hereditary form or do you have the wild type or the unmutated or the acquired form? Those names are a little bit complicated, acquired and wild type, but the senile systemic is probably less, that's what it used to be called. So I think wild type and acquired is a better name for it. Genetic counselling should be offered to anyone who's going for genetic screening. It doesn't necessarily mean that you need to meet a genetic counselling specialist, but you need to meet a physician who's aware of the implications of what this genetic test will mean for that person, but also for their family. This will lead on to the next kind of third group. The first degree relatives should be offered pre-symptomatic cascade genetics testing. And this is a bit of work, so it's where that you map out all the first-degree relatives and you do the gene test routinely. What that allows you to do in a service approach delivery to patients is that you then find the potential for that person to have amyloidosis. So your pool of following the whole family means that you follow the ones that have a genetic mutation. So then you can then work out when should they have their DPD scan, when should they have their MRI, when should they have the nerve conduction studies, at what point in their predicted disease state. And that then hopefully would allow you to achieve the state that I'm really happy Roisin achieved, was that her diagnosis was made 2 years early before she was going. And that's what we really want to achieve with our patient group, is we know that some of our patients that are put on gene silencing therapies have progressed and died because probably their heart was so badly affected. So again, trying to get that balance point where the disease has begun but not at a start level to start the treatment is going to revolutionise treatment. Lastly, this is the people without symptoms who may have ATTR variants, so the relatives of people. And this really, you have to really determine the risk for developing ATTR amyloidosis. You need to reflect on the gene penetrance, and I'm really happy to see the really seminal papers included in the pack of Mary Riley. And we really did great work, and that was really gave us an idea of what the penetrance was for the T68 variant. However, I've talked to Mary about this on and off, and we know that probably a little bit more work needs to be done to see exactly with her newer technology, is it really 80% or is it higher or less? So I think we can predict a person's phenotype a little bit better with some of her newer scanning and testing. There is a central role in this case for genetic counselling, and all patients should be linked with an amyloidosis specialist or a centre, and that's critical because you have the gene, brings a huge amount of worry, you're trying to think of the symptoms, and there's been many patients that I've met on treatment and before treatment that experience the psychological burden of knowing their mum or their dad or their brother or sister, and in some ways they start feeling symptoms that may not actually be picked up on imaging or objective testing. So again, the emotional issues around this diagnosis can't be underestimated, but I hope that this is a new dawn for the disease, as Roisin was saying. Lastly, I'll just talk briefly on the model of care, and this is kind of a terminology that probably you won't be familiar with, but when you try to work within the system of the HSE, and the HSE has a lot of problems, I'm sure, like the NHS in the UK, but you have to work within something to try and push something forward. And I'm really happy that it was cross-border. We did have 2 different individuals from the north that participated in our working group. It took a lot of work to formulate what a report around all the issues of not just one single amyloidosis, but what would the needs be for the service. So you'll have seen from Ashline's talk that even a neurologist in neuromuscular has shortcomings in terms of her specialist nurse cohort, so like for the 20 that's required. So what would the service require? So that's trying to predict what we would need and then to create estimates to provide that service. In model of care design, there's 5 different phases, and the phase 1 is to see what is the issue. Are people being undiagnosed with H90D? Are the people being undiagnosed with ATTR wild type? Then you try and see where are the problems. So do we not have enough neuroradiologists? Do we not have enough neurophysiologists? Do we not have enough neurologists? What is the problem? Is it that the geriatricians don't know anything about amyloidosis? Is it a learning problem? So where are all the different pieces? Then we go to the point of trying to provide a solution, and that's what the working group did. And I'm very pleased to have had 2 patients affected by 2 different types of amyloidosis on that working group, and unfortunately both of them have passed away, but they were instrumental in also shaping a report that it represented the voice of what a service should be for patients. So arising out of the first 3 phases, we did come up with a model of care in a working group document. It was submitted in just after the pandemic occurred, September 2020. It took probably 2 years to get to the clinical forum, which is led by the Chief Clinical Officer, Dr. Colm Henry. So this is how slow things work. And this is meanwhile while Patrician was trying to be approved, and all of us were involved in different ways to try and push that approval within the South. But thankfully, you have to be patient, you have to work and remind, and these people are busy. That document then goes to the clinical forum and you present the working group report. And that was presented in December 2021. And then finally it received approval 2 weeks ago. So the next step is that we go to implementation, and then we see what we implement, is that sustainable? Is it meeting our needs? We constantly audit and see, okay, well, we thought we needed 20 nurse specialists or a neurologist and neurophysiologist, but it's actually not what we need. We need less or we need more. So it's trying to build the service. The current model of care is mapping out when that person says, I think there's something wrong with my hand or my heart, the first moment they come in contact with a healthcare professional, and then they go out the other end of having a treatment or a diagnosis. So the current model of care, because the new model of care hasn't been implemented, patient presents with symptoms suggestive of amyloidosis or attends for screening. They're seen by a specialist in whatever discipline. The assessment is completed. Some of them, and a proportion of them, and I do agree with Sinead that some of our patients, particularly some of the AL patients, may not be fit enough to travel to London. And we're really, really grateful for all the work that Julian, Ashu, Phil, Helen and Carol do in the Royal Free. And then treatment is started in Ireland. Then at times, and again, the workload in the Royal Free has increased exponentially, and Julian probably tell you about that personally. They're seen periodically then at the Royal Free, depending on which type they have. This is sort of it mapped pictorially, doesn't project that well. And if we move on then to the new model of care, the patients present with symptoms suggestive of amyloidosis. They're referred to a complex care centre or network in Ireland. The assessment is completed. Then the higher risk cases are treated in complex care. The lower risk cases are treated in level 2 or 3 or community. Then they're seen periodically at the complex care centre. One of the difficulties, I suppose, that when I worked at the NAC, we did review the Irish case that attended for care in the NAC. And one of the issues in terms of AL amyloidosis, that developed cardiac disease would often be referred to the Mater Hospital in Dublin. But the cardiac cases are often the most tricky cases in AL amyloidosis. But invariably, when we looked at patients that had cardiac disease, they invariably all died. And you would sort of say, well, why is that the case? And the case is that there are high-risk cases that need complex management. And if it's outside of kind of a care centre, there can be issues with monitoring and giving the appropriate management. So if we look at what the model of care would look like, this is it done pictorially, that you have this complex care centre or network, and then you link back into the community care or the non-complex level hospital base. The community care is absolutely important, and we were really fortunate to have Dr. Delap, who's from Bumbeg, out the road, on our group, and he gave some insight into what would be supplied through the community. And part of our health service delivery with the HSE and possibly in the NHS is trying to shift the focus from hospital-based care to community care. So giving the drug like we do with patisiran in the person's home, rather than bringing them into a hospital. And like, as Sinead said, opportunities and things that we can't do that really, changed during COVID, that these things could happen because hospitals then had to be kept for more emergency care. I'm really happy to see what Aisling was talking about, because we proposed 10 different gates. So one of the model of care we wanted to do, and there's a really good, she was the former head of the Children's Hospital in Crumlin. She was really, really insightful. She goes, okay, you have a model of care, that's fine, but can you tell me things that would actually prevent them getting really high burden disease? We don't want them to have heart failure. We don't want them to have renal failure. We don't want them to have X, Y, and Z? Can you tell me things that we can pick them up early and then they won't develop the complications of the disease? So she put in mind that we develop a gate structure. So we developed 10 gates of trying to get all forms of amyloid sooner so they get on the appropriate treatment. And I'm really happy that Aisling is already using one of those without the model of care being rolled out. But one of them is the carpal tunnel syndrome, that if you do a biopsy or release, people usually just release the carpal tunnel and they don't take any tissue. You take tissue, send it down for typing. Julian and a number of colleagues at the Royal Free have looked at this, and it really, really is impactful in terms of trying to get people diagnosed earlier. The other ones that's quite relevant, I suppose, to this talk was around family genetic screening. So we have said one of our critical gates in reducing the burden of disease of inherited or variant amyloidosis is to screen family members. And then, but along with that is that we would provide the service that would be able to tell them when we need to start treatment. There's no point having a gene test and then not being able to say, well, actually your nerve conduction has changed, or your DPD is changed, or your cardiac MRI, or whatever biomarker we use to define disease progression. There's a lot of work looking at nuanced biomarkers such as BNP, neurofilament, other kind of clever markers that you may never need to have a test done to predict when we should start treatment. So the next steps in terms of this is that thankfully the working report took 2 years to read. I suppose it was long. Was approved by the Clinical Forum, and they will now push it as this will be adopted as a model of care. It's been now sent to a part of the HSE called the Implementation and Strategy section. And I suppose people that work in the NHS like this is the commissioning part, and then you'd be up for whatever hospital group or hospital network to say what they're going to require to roll out the model of care. This report was not linked to any specific hospital. There's representation across all hospitals and all different groups: pathology, nephrology, cardiology, neurology, neurophysiology, GP, and then patient representation. Once it's implemented, there'll be problems with it. You need to tweak it a little bit. And that's the fifth part of developing a model of care, is that you check the sustainability and you monitor, review, and you optimize. So in conclusion, in terms of pathways for genetic testing, we do have recommendations that are really designed for UK and Ireland population. Previously, the recommendations were largely looking at the V30M and other variants, that we don't see that commonly in Ireland, but we are seeing a little bit. We have a huge Brazilian population in Ireland, and the V30M is endemic in that population. Again, we now have to develop the pathway of testing in line with the proposed model of care. I thank you for your attention, and I really thank Rosalina, Roisin and Oscailga and our colleagues. Go to Míle Mágaibh.